some key information. First of all, Happy New Year to everyone. Welcome to the Neonatal Hemodynamics Targeted Neonatal Echo Foundation's curriculum. This is the first session we have in 2025, so it's going to be extremely exciting. Before presenting the upcoming presenters, I just want to give a few key information for everyone. First of all, I do want to mention a bit about the format so everyone is aware. We are starting with a webinar, which is open to a broad audience, and our presenters will have presentations on a key hemodynamic aspect of the practice. And after the presentation, there will be the opportunity to ask questions via the Q&A box. So please make sure to put your question via the Q&A box so that we're able to ask these to our presenters. Following that, there will be a smaller session really geared for our trainees, fellows, young faculties in neonatal hemodynamics. And for that, there will be a specific link that will be sent to the panelists, which include the presenters as well as the fellows and young faculties. So please make sure to log on the second part, which will not be recorded and which will be interactive with our presenters. On this note, I also want to mention that the Neonatal Hemodynamics and TNE Foundation curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. So big thanks for them to supporting that. We are accredited by the Royal College of Physicians and Surgeons of Canada in order to have Section 1 maintenance of certification credits. And then importantly, please scan the QR code and fill up some of the surveys and evaluations following this session so that we can use that to continue to bonify the curriculum and program as we use that to tailor the presentations and topics as well as the formats. So on this note, I really want to thank our two presenters today. The first ones of 2025 who will be presenting in the pharmacology of hemodynamics. We have Dr. Christopher McPherson, who's a PharmD, graduated from the University of North Carolina School of Pharmacy, completed a fellowship in neonatal pharmacotherapy at the Women's Hospital of Greensboro. He practices as a clinical pharmacist in the neonatal intensive care unit at St. Louis Children's Hospital and serves as an associate professor in the Department of Pediatrics at Washington University School of Medicine. His primary employment is as a medical science liaison for SOBI Inc. We also have Dr. Irina Prelipcean. She is a staff neonatologist at the Golisano Children's Hospital and Associate Program Director of the Neonatal Perinatal Medicine Fellowship Program and Assistant Professor of Pediatrics at the University of Rochester. She has trained in targeted neonatal echocardiography and is developing her research in hemodynamics and in biomarkers involved in neonatal brain and adrenal dysfunction. So on this note, thank you both for putting together this presentation, and the floor is yours.
I'm not sure. I think that's the case.
Right. Thank you so much, Gabrielle. Thank you for this opportunity. And I want to say hello to all the friends I see online. And I'm excited to talk about the tiny hearts and the big drugs. And hopefully we can tackle it along. Please let me know if you don't see the slides or if there's any issues. All right, so I have no conflicts of interest, but this is my one big disclaimer that the recognition that being a neonatologist and managing a sick neonate with circulatory failure is much like being a chef cooking a very delicate dish with limited ingredients and a very incomplete recipe. We're all guilty of reaching out to the most familiar ingredient we have, dopamine, and usually that happens at 2 a.m. because that's precisely when all the babies decide to misbehave, and praying for the best. but we are doomed to fail in some babies because in situations of high risk for circulatory compromise, there are a range of hemodynamics. And what's logical in that sense is not is to define individual hemodynamic in a baby and then apply therapy based on this individual findings. If we apply the one size fits all, of course, we are doomed to fail. So what we hope with this talk is give you a better understanding of the ingredients that you have at your hand and clarify that recipe a little bit. And I'll start with why do we care even about the subject? We've gotten really good in neonatology in the past few years, or in the past, 50 plus years at improving our preterm respiratory care in such way that the greater proportion of death occur not because of respiratory causes like they used to be in the past, but more to episodes of sepsis, NEC, where impaired kind of myocardial function and failing peripheral vascular control make circulatory failure the final mechanism of death. There's good, ample evidence that hypotensive babies have worse neurodevelopmental outcomes, and treating that improves survival. However, the use of antihypotensive medication in a kind of regimented fashion, the one-size-fits-all kind of fashion, it's associated with an increased risk of death and neurodevelopmental impairment. Also, when it comes to cardiac health, we've known for a few years now that forward preterm babies grow to be young adults who have 17-fold increase in heart failure risk, and then one and a half fold increase in young ischemic heart disease. And although we don't know exact mechanisms behind this, we can presume that some of the NICU cardiovascular management is potentially a modulator for those. And if we practice neonatology for a little bit, we know that our preemies, our babies in general are exposed to at least one vasoactive medication in their lifetime. About 30 to 40% of them are exposed to medication. So we are using them often in the NICU, and it's important to know how to. I think I'm preaching to the choir for this group specifically regarding the clinical impact of a hemodynamic precision. But I definitely wanted to highlight several publications that came out recently from centers in the US and Canada. All right. That support, and it's exciting that they support the significant clinical impact of hemodynamic appraisal for critically sick neonates in the NICU with improved mortality, reduced kind of mortality across the board. And we can't have a talk about big drugs, about precision hemodynamic without highlighting some of the cardiovascular physiology concepts. So I'll go to just quickly. You've most likely seen a version of this slide, but the aim of circulatory competence is to maintain cellular metabolism, and you and I have a redundancy in delivery that's imperative for our ability to tolerate stress. So our normal oxygen delivery to oxygen consumption is about 5:1. Cardiac output and an adequate blood oxygen concentration determine the cellular metabolism. And many of you know that the cardiac output is determined by preload, afterload, contractility, and heart rate. It is, I highlight the slide because it is important to think about things that we can manipulate. So we can manipulate the components of that oxygen delivery, heart rate, preload, afterload, and then specifically not to forget the hemoglobin, the blood oxygen content is also very important. Outside the kind of the normal determinants that we think about, preload, afterload, contractility, it's important to understand that there are other determinants and challenges when it comes to neonatal cardiovascular system, especially emphasizing the interplay of the systemic and pulmonary circulations. For example, preload is dependent on 3 factors. You have the intravascular blood volume, you have the diastolic compliance of the ventricle, and also the changes in pulmonary vascular resistance, which oppose venous return if increased above the physiological level. So all those are important consideration when thinking about hemodynamic appraisal. And it's even more important to understand kind of this clinical phenotype in premature pathophysiology, with their poor tolerance to increased afterload, reduced diastolic filling, and the knowledge that vasoactive drugs have a predominant vasopressor effect, and the inotropes not being as effective in improving contractility. And having, although you and I have those reserves in our system, the cardiac reserve is very limited when it comes to preterm babies, and they have a high resting vascular tone. So all those determinations or determinants of their cardiovascular risks are important to be known. And I, don't think I need to make a point for this further, but the complexity of this system is magnified many times in a newborn. We're dealing with transition. We're dealing with fetal channels. We're dealing with high states of pulmonary vascular resistance, and there's scientific evidence that has failed to support a rigid recipe when it comes to vasoactive medications in neonates. I want to spend a little bit of time talking about blood pressure because it's one of the things we hang on to in neonatology. There is no known evidence to support that mean blood pressure is a reliable determinant of clinically significant hypotension. There's some discrepancy in all references that we have so far for values in blood pressure and babies. And there's no known cutoff limit for BP that can predict clinical outcomes. The low blood pressure in itself is not an independent predictor of clinical outcomes. There's not a single blood pressure component that's considered the best predictor outcome, and there's no single reliable hemodynamic parameter in itself for clinical assessment. And many of you have seen this before, but it's important to highlight that mean blood pressure does not predict cardiac output, and there's not a direct relationship between the two. And relying on the tendencies to rely on blood pressure as a sole assessment of circulatory compromise is not the way to address hemodynamic appraisal. So in the series of things we don't like to admit, but we've done it, and I've done it myself, we resort to fluids first before we were trying to figure out what's happening with the baby and figuring out what the individual hemodynamics are. It is important when assessing hemodynamics in an individual baby that to understand that we need both a measure of pressure and a measure of flow so we can estimate the resistance and derive if flow or resistance or both are needed to increase and support the blood pressure. So what's essential to have is a measure of systemic blood flow, a measure of blood pressure, and organ blood flow, and an estimation of what pulmonary blood flow is. And ideally, it's nice to have a measure of preload of volume status, and specifically the blood flow distribution to the organs, which is a little bit harder. In functional echo assessment, it's important to document structural normality, fetal channel shunts, volume status, myocardial function, and estimated pulmonary pressures. And this, summarizes there's a lot that goes into a hemodynamic appraisal with our considerations that I talked about, but this is integrating the clinical data that we have in our hands, talking about rhythm, normal rhythm of the heart, hypotension, medications, cardiopulmonary interactions, and all those things that go through our minds when we look at our baby alongside the echo data. I'll spend just a moment talking about the assessment of the left or right myocardial function, with a consideration that many of those measurements are load dependent, so the flow and fluid status are important. When we look at the assessment of function, probably the one that's least load dependent is the deformation, the strain rate measurement. So in the absence of a simple technique to measure cardiac output, clinicians have to rely on blood pressure, but the idea is that, in order to take care of the kind of the circulatory compromise, there are two main goals. One, to rapidly identify and treat the underlying cause of shock, and improve the tissue perfusion and oxygenation by obtaining a minimum acceptable cardiac output and blood pressure, with whatever hemodynamic support strategies we have at hand. There are four basic mechanisms that we have to keep in mind, and those are reduced intravascular volume, so low preload, obstruction of the circulation, that's a high afterload state, the loss of vascular tone or distributive disorder in the peripheral circulation, and the intrinsic or extrinsic compromise of the myocardial performance. And just to note that microcirculatory shock is also a condition that we can have in babies where the microcirculation failed to support the oxygenation of the tissue, even with normal systemic hemodynamics. So I'll take a few clinical scenarios to try to go through some and identify some hemodynamic phenotypes. So we have a 24-weeker, 500 grams, preterm labor, and admitted to NICU after delayed cord clamping. The APGARs are 7 and 9. There's no maternal risk factor. Intubated in the delivery room. Soon after admission, we noticed systolic hypotension. So based on this clinical data, which hemodynamic phenotype best fits the case, and how do we want to treat? So we'll take some scenarios to go over, how we would approach a baby like this. I shared this resource with a group, and it's kind of a nice framework to identify the hemodynamic profile. Again, it's not a recipe for exactly how to treat the baby in front of you, but to give you an idea of what that would look like. So in the case of our baby that was just born, this is likely an increased afterload state, consistent in the setting of transitional circulation. Likely, we don't have to do anything. We can wait and maybe have to support contractility with dobutamine. This is one of the cases that we may guess kind of the pathophysiology or the hemodynamic profile even before we have the echocardiographic data. That's not the case for all the babies. But we, of course, have to confirm that what we think clinically is correct and the hemodynamic profile is correct. Now moving on to another scenario. So we have now X28-weeker. It is, we're now 31 weeks, have abdominal distension, dilated bowel loops, pneumatosis with on abdominal x-ray, is hypotensive with delayed bonding pulses. So let's again think about what, based on this clinical data, which hemodynamic phenotype best fits this case and how we may approach the treatment in a baby like this. We're likely in, it's easy for most of us neonatologists to say, well, this is neck, right? We're likely in a state of septic shock, warm, because we have bonding pulses. So as long as, even though we have a vasodilatory shock, as long as the myocardial performance keeps up with this increased workload, there's normal or systemic blood flow. When we don't have, when we can't keep up with this workload, then we may choose to support with, improve the LV filling and increase the systemic SVR. So something like norepi, vaso, or dopamine in absence of pulmonary hypertension would work in this case. Another scenario where we have a preemie baby, 500 grams, preterm labor, admitted to NICU, similar to what we had in case scenario 1. After delayed cord clamping, APGARs are 7 and 9. There are no maternal risk factors, intubated in delivery. Now we're 48 hours after admission and has diastolic hypotension and low mean arterial pressure. Based on this clinical data, let's think about what the hemodynamic phenotype would best fit this case, just on the clinical data, and how we'd approach that. So this is most likely consistent with a baby who has a PDA physiology. In this case, the best treatment would be shunt mitigated strategies. Trick question, and a little bit of a tricky scenario. These are, again, scenarios that are based on just clinical data to try to identify, before we even have more of the echo criteria, the hemodynamic phenotype. So let's try to learn a little bit more about the ingredients we have at hand, so then we can integrate in some more complicated or a little bit more complex cases. And this is my summary of the big drugs. But thank God we have Dr. McPherson to delve in a little bit more about, again, what we have at our hands to help babies.
Thanks so much. So I do think this slide does a phenomenal job of summarizing the place of these drugs in the current neonatal paradigm. I want to emphasize in this portion of the lecture that the pharmacology is relatively straightforward, and definitely by comparison to the physiologic and diagnostic complexity. So if you, as physicians, can get your skills optimized on those fronts of diagnostics, application of the pharmacology should be a small hill to climb after that. So let's look at the available data for these agents. We're going to try to tie together receptor activity with pharmacologic activity of the drugs, and then therefore clinical impact based on the data we have available. So this phenomenal slide from Reagan Geisinger shows the applicable adrenal receptors that you should be familiar with when you're thinking about this pharmacology. Alpha-1 receptors in the heart increasing contractile force, beta-1 receptors increasing heart rate and having an even more dramatic impact on contractile force. Alpha-1 receptors also exist in the peripheral vasculature and are potent vasoconstrictors, as are alpha-2 receptors in the peripheral vasculature, which exert that effect through increasing norepinephrine release. And then finally, beta-2 receptors in the peripheral vasculature causing vasodilation through decreased vasoconstriction. So thinking about the most common vasoactive medications in the neonatal intensive care unit, we first think about dopamine and epinephrine. Dopamine acts at moderate doses as a beta-1 stimulant, increasing cardiac output. And as you increase the dose, you pick up alpha-1 receptor stimulation and have vasoconstrictive effect. This contrasts with epinephrine, that at lower doses is a profound beta stimulant, both beta-1 and beta-2 receptors, but at relatively low threshold doses, so I categorize those as medium doses here, you get a profound vasoconstrictive effect, both through alpha-1 and then postsynaptic alpha-2 receptors. We do actually have randomized control trials that compare these two agents in preterm babies, and you can see that they both reliably, at moderate doses, increase mean blood pressure by increasing systemic vascular resistance. The right side of the slide is incredibly important because it highlights the physiologic paradigm that Dr. Prelipcean described so eloquently in her initial slides. So you can see that in these same babies, they're all having dramatic increases in mean blood pressure after initiation of these vasoactive agents. Some of them have tremendous response in terms of cerebral intravascular oxygenation. These are very positive responses. However, these poor babies on the lower end have dramatically negative responses to this increase in mean blood pressure. So although the drug is reliably doing what you want it to do, that can have a very positive or a very negative impact on the baby's physiology, depending on the underlying cause of their systemic hypoperfusion. So please keep that in mind. When you're comparing these two drugs head to head, what are the differences? As I said, effect on mean arterial pressure is identical. However, epinephrine has a profound impact on heart rate via beta-2 receptor stimulation, thinking back to that initial slide. So you will see tachycardia with epinephrine that you don't see with dopamine. Epinephrine also drives up serum lactate levels via beta-2 receptor stimulation in the liver and increases blood glucose via a similar mechanism. So when we're contrasting these two drugs as vasoactive agents, the standard approach in neonatology for decades has been to grab dopamine because it has similar vasoactive properties with a lower adverse effect profile at vasoactive doses. Now, this doesn't speak to epinephrine as a inotrope at lower doses. There's limited data supporting that role of epinephrine in clinical practice, although it's used widely and very effective as long as the doses remain below these vasoactive thresholds that are associated with some systemic adverse effects. The inotrope that we do have clinical data on in preterm neonates that's relatively robust is dobutamine. So contrasting the mechanism of dobutamine with that of dopamine that we've already covered, you can see that dobutamine does have some very limited alpha-1 activity, but also potent beta-1 and beta-2 stimulatory effects. So when we initiate dobutamine, we expect increased cardiac output with some degree of systemic vasodilatation. Whether or not this systemic vasodilatation augments or harms systemic circulation depends on the underlying physiology of the baby being treated. In terms of clinical data, it reflects the mechanism of the drug. You can see that dobutamine reliably increases cardiac output at clinically relevant doses. It does this without a profound impact on heart rate, but with a variable impact on systolic blood pressure, again, likely mitigated by the underlying physiology of the baby receiving that agent. These data come through really clearly in a randomized control trial out of Australia from several decades ago, summarized in a recent or a more recent review article by Nick Evans. Just very simplistically, what this slide says is that dobutamine does not reliably change mean arterial pressure. Now, can it increase or decrease mean arterial pressure? Absolutely. But the average baby receiving dobutamine will have a null blood pressure effect. That's not the case with dopamine. With dopamine, reliably, you'll see increases in mean blood pressure. There's a very minority of babies that don't have that effect from dopamine. However, contrast that with changes in cardiac return from the SVC as a marker of cerebral blood flow. In newborn babies that are likely suffering from immature myocardial contractility, you can see that dobutamine is a more reliable increaser of SVC return as compared to dopamine. Now, you have to acknowledge the extreme variability in these effects in individual babies within this randomized control trial. What the heck is going on there? It's not variable pharmacologic response to the drug. The pharmacology is generally reliable. It's different underlying physiologies in the babies. If you're treating immature myocardial contractility with dobutamine, you expect to see profound improvements in systemic blood flow. However, if you're treating septic shock and capillary leak syndrome with dobutamine, you're probably going down the wrong path and could have negative effects from that intervention. So again, tying together physiology and pharmacology to clinical effect is profoundly important. This slide summarizes the data that I just presented, and I hope that it made the case that dopamine is a useful agent for babies with dilated systemic vasculature. Dobutamine is very useful as an inotrope. Epinephrine is generally reserved for shock in neonates because it has an adverse effect profile that contrasts negatively with dopamine. This is traditional vasoactive medication. So what about all the new kids on the block? So the first new kid we think about is norepinephrine, because I talked about the vasoactive activity of dopamine and epinephrine, but those aren't clean vasoactive agents. They both have cardiac effects that may be very positive and also may be very negative, depending on that baby's physiology. But in contrast, norepinephrine is a more pure vasopressor. So regardless of the dose, you're going to get some beta activity with norepinephrine, but that activity is going to rapidly be drowned out by potent stimulation of alpha-1 and alpha-2 receptors, causing profound systemic vasoconstriction that will blunt any increases in cardiac output through beta stimulation. Dr. Prelipcean put together this really phenomenal review slide that reviews data over the past decade or more about how norepinephrine has emerged as a clinical practice commonality in neonatal intensive care units. So this slide is for your reference. I just wanted to highlight a few publications from that slide that emphasize the effects of norepinephrine in clinical practice. As I said, it's a profound vasoconstrictor, so reliably increases mean arterial pressure in treated neonates. The real draw of norepinephrine over traditional agents like dopamine and epinephrine doesn't actually come from neonates. It comes from randomized controlled trials in adults with septic shock. And in those randomized controlled trials, there was a trend towards survival benefit when adults with sepsis were randomized to norepinephrine as their vasoactive agent over dopamine. Why did this occur in adults? It occurred because of the high rate of adverse effects from dopamine, specifically cardiac arrhythmia. So in my mind, those cardiac effects of dopamine that are less pronounced in norepinephrine have a profound implications for treatment of adult septic shock. Is the story the same in neonates? It's foolish to assume that it would be identical in the absence of data, but the thought process is similar in clinicians who are prescribing these agents. The data for norepinephrine in premature neonatal septic shock is limited, and that's a data field that we need to expand. But the data for norepinephrine and PPHN, I think, is relatively compelling, so I'll share that with you as well. This is preclinical data from Satyan Lakshan regarding dopamine. And in this mouse model, he showed that when you initiate dopamine, you have an equivalent impact on both systemic and pulmonary mean arterial pressure as you increase dose. So proportionate impact. Now, as we think through PPHN physiology, a baby with hypotension, but also persistent pulmonary hypertension, we do need to normalize the systemic blood pressure. But if we do that with an agent like dopamine, we're also driving up the pulmonary vascular resistance and therefore not aiding our right to left shunt in any way, shape, or form. This contrasts dramatically with norepinephrine, which in small studies of neonatal patients causes an actual decrease in pulmonary vascular resistance, therefore having an increase in pulmonary blood flow in the setting of PPHN physiology, resulting in improvements in oxygenation. So pulmonary arterial pressure is relatively stable while systemic arterial pressure goes up, decreasing the PAP to SAP ratio and allowing for weaning of the oxygen, supplemental oxygen in these babies who are experiencing PPHN physiology after norepinephrine treatment for hypotension. If norepinephrine is compelling for this indication of PPHN, then vasopressin, as an even newer kid on the block, is really exciting. So how does norepinephrine work? It actually doesn't work through these alpha and beta adrenoreceptors at all. It works through vasopressin receptors, with V1 stimulation causing systemic vasoconstriction and pulmonary vasodilation. If you want a recipe for success in hypotension with PPHN, this is it, right? V2 receptor stimulation has antidiuretic effects, and that should be kept in mind as you're monitoring urine output as a marker of systemic perfusion. Again, Dr. Prelipcean has done a phenomenal job of summarizing the literature regarding vasopressin as it has emerged in neonates over the past decade. Highlighting some of those publications, you can see that in models of septic shock, vasopressin reliably increases mean blood pressure. Remember the mechanism. If I can flip back a few slides, you don't have to stimulate adrenoreceptors. So regardless of the cortisol status of the baby, vasopressin can exert a systemic vasoconstrictive effect, whereas dopamine or epinephrine may not because of adrenal insufficiency. There has been a small randomized control trial conducted by Daniela Rios in her time at Houston when she randomized babies with hypotension to vasopressin versus dopamine. Those results are preliminary but promising. They showed that both drugs exerted a similar vasoconstrictive effect in premature neonates, but vasopressin did it with a much less profound impact on heart rate as compared to dopamine. Flipping over to the PPHN population, which I think is the most compelling in terms of vasopressin use, you can see that in neonates with PPHN, vasopressin reliably increases mean arterial pressure, but it does that in a systemic over pulmonary fashion. So you're getting a profound systemic vasoconstriction with systemic vasodilation, which will hypothetically dramatically improve or flip that right to left shunt. And that's what the clinical data shows. You can see profound improvements in oxygenation index in patients who are given vasopressin after the initiation of nitric oxide, show phenomenal responses in terms of oxygenation index, which I would not expect with an agent like dopamine that is simultaneously driving up pulmonary vascular resistance. The final drug that we'll talk about as we've shifted to PPHN is milrinone. So this contrasts with dobutamine as a potent inotrope. In contrast to dobutamine, milrinone acts as a phosphodiesterase 3 inhibitor, which causes downstream inhibition of cyclic AMP formation, which causes potent pulmonary vasodilation, as well as dramatic increases in contractility and repolarization through calcium and potassium channels, respectively. So pulmonary vasodilator, potent inotrope, which again lends itself very nicely to pulmonary hypertensive physiology, in that physiology refractory to nitric oxide. So again, Dr. Prelipcean has summarized the literature for your reference and highlighting some of those studies. You can see that milrinone reliably in the setting of PPHN increases right ventricular output with a transient decrease in mean arterial pressure, but an improvement over time. You also see dramatic improvements in oxygenation index, again, simultaneously through augmenting cardiac output and dilating pulmonary vascular resistance. And with that summary of the drugs, I'll flip it back to Dr. Prelipcean for application.
Thank you so much. Another one in the series, things we don't like to admit, but we've done. We talked a little bit with Dr. McPherson that did an excellent job talking about epinephrine. We've all been in the situations of having to push epinephrine and praying really hard. So one of the questions that we posed ahead of the lecture was to describe the stepwise approach to initiating and titrating epinephrine in a hypotensive neonate. We probably outside dopamine and dobutamine, epinephrine is one of the third used so far in our NICUs. And I would say and hope Dr. McPherson agrees, you would start with epinephrine of 0.03, titrate every 10 to 15 minutes based on the blood pressure and perfusion. Now, keeping in mind what it was nicely highlighted during the review of Vasoactives, that at doses less than 0.05, not a lot of evidence, but still at the lower doses, we get more the beta stimulation, the inotropy, with increased in cardiac output and potentially reduced in PVR and SVR. And then we have kind of a gray zone between 0.05 and 0.1, but definitely above 0.1 micrograms per kilogram per minute. It stimulates the alpha receptor, so you get the increase in SVR and also the PVR, and may reduce the cardiac output in those. Obviously monitored carefully for side effects, and adjusting the dose as needed, or going to a different vasoactive medication. Let's take another clinical scenario and try to think about some of the things that we learned about the vasoactive medication. So now we have a 25-weeker, poor perfusion, high lactate, who requires increase. So we started with dopamine. Why? Because that's what we did. Increased dopamine to 15. The heart rate is now 190, and there's a refractory hypotension. So based on this clinical data, what hemodynamic phenotype best fits the case, and then kind of thinking out loud what we do next, we would add something, increase dose, or even stopping therapy. So I think we agree that that at this point in time, we're refractory, we're in circulatory failure, we're not meeting the demand of the tissue. And somehow we have to restore some cardiac output and some circulation, and may or may need some volume support and other vasoactive medications. So what we could potentially do is maybe decrease the dopamine dose and use some volume. And if we are in trouble at that point in time, vasopressin would be maybe useful to avoid the chronotropy, as Dr. McPherson emphasized, to be able to increase that augmented that preload. So how do we initiate, titrate, and stop vasoactive medications? I would say what makes sense is to start low, go slow, and look for the signs of effective, not just effective response, but physiologic response. And then think about why we're not responding, or not just responding, but we have an undesired effect. So did we select the wrong drug that doesn't fit the pathophys that we think we have in front of us? Do we have severe acidosis? Do we have suprarenal or adrenal dysfunction? Is there something in the lung, so a coexistent parenchymal lung disease that we have to address in a different way? And do we have an overlap of multiple physiologic mechanisms? And for you out there who do frequent hemodynamics assessment, you probably know that happens quite a bit of a time. So trending clinical and echo findings frequently in a very sick infant is key, because of the potential of rapidly changing physiology. So now I'm taking you on another scenario. In the last few minutes, we have a full-term baby, non-reassuring fetal heart tones, delivered via C-section. They're poor APGARs. Cord pH is 6.8. You know, as I'm talking, you know what's happening. Intubated and cooling. A few hours after admission, becomes hypotensive, has metabolic acidosis, desaturations. Based on this clinical data, which hemodynamic phenotype best fits, and how would you treat? This is very difficult to identify based just on the clinical data. I would say this is the point in time where you need the clinical data, but you also need the pre-treatment echo to be able to identify what's going on. Any of those hemodynamic profiles can be true. And let's say this baby is a neonate with mixed phenotype of septic shock and acute pulmonary hypertension, and I threw in some RV dysfunction in there. So how would we manage this baby? We would begin with vasopressin and to improve the systemic vascular resistance, support systemic perfusion without getting the increased heart rate and having appropriate filling. Alternatively, we can use norepi. And then maybe add milrinone low dose to reduce pulmonary vascular resistance and improve right ventricular function while avoiding the excessive systemic vasodilation. Again, we have to monitor therapy effect. I'm not saying this is the only way to go, but this would be one approach. Monitoring the effectiveness of therapy, and then frequently reassessing all our clinical and echo data, and monitoring for those adverse effects that we may have. So all drugs are bad. And I state that lovingly, but they are. We're on the same page on that, and they should be titrated cautiously as per desired effect. Some case scenarios may have, as I mentioned, multiple underlying pathophysiologies. It is essential to prioritize the line of treatment directed by an expert in neonatal hemodynamics. I think hopefully we made that point clear, and recognizing harmful phenotypes that can creep in our with our treatment or even before we start treatment, like LV outflow obstruction, impaired diastolic filling, in order to avoid placing a baby in that kind of or exacerbating their instability. So what are the risks of using INO in a neonate with left ventricular diastolic dysfunction? Ino can increase pulmonary venous return, exacerbating left atrial pressure and pulmonary edema and LV diastolic dysfunction. So in conclusion, we know a lot about how our interventions affect blood pressure, less about how they affect the hemodynamics. We have some idea, but not entirely sure in some of the cases, and almost nothing about how they affect outcomes. So the only logical way in this case in neonatology is to approach the circulatory support is to use an individual or precise-based approach. And we should try to define it, the individual hemodynamics, as accurately as possible. Sometimes we're wrong, even with all the tools that we have, and apply the logical treatment based on what we know about the effects and the interventions on physiology, and reassess, reassess, reassess. I have a few QR codes for those resources. You already have those, and but if you want to snap quickly the links.
Perfect.
And this is what
sorry.
we'll end just quickly. This is a stolen slide from Phil Levy. I really like this recipe, and it kind of I use it clinically, so I have it in here for resource. And then our emails are, the top is my email, and Dr. McPherson's email is at the bottom. If you want to snap those quick, if you have questions outside this session. I like to end with the fact that we've grown so much in the past 50 years, and I'm excited to see where we're going in the next 20 years. Thank you.
Fantastic. Thank you so much to both of you for such a comprehensive and really spectacular review of the pharmacology nested within clinical settings.
Okay, in the interest of keeping us on time, I will go ahead and get started. So thank you everybody for joining us on this special session. So our December session of the Targeted Neonatal Echocardiography, Neonatologist Performed Echocardiography Foundations curriculum. So this session will be a little different than the normal one. It's on the topic of mentoring and development in neonatal hemodynamics. And so there will not be a special session for the trainees only. So we will just all be in this session the entire time. So I do want to thank everybody for joining us on behalf of my co-chair, Gabriel Altit, as well, who is unable to make it today to the session. We hope that you are enjoying all these sessions and getting something out of them. And I think this one will be one of the most beneficial to a lot of people. So I just have a couple of housekeeping reminders. If you have a question, if you're a panelist, feel free to actually turn your video on the entire time. You can actually have your video on if you would like, and then unmute yourself to ask questions. If you are in the broader webinar, please put your questions into the Q&A box so that we can address them as a group after the talks, the 3 talks that we have for you today. So I will then turn over the session to our 2 moderators, Shovik Mitra and Adrienne Bischoff, and we can get started.
Hi, everyone. Welcome. And I'm going to start by introducing our speakers ahead of time because there's 3 people here today, and then we'll go ahead with the individual talks. So the first speaker for today will be Dr. Jack Wren, who's a clinical assistant professor and neonatologist here at the Steed Family Children's Hospital in Iowa City, and he is our most recent graduate from the Neonatal Hemodynamics Fellowship this past summer. He will be followed by Dr. Marjorie McConey, who is an assistant professor and director of the TN Echo Hemodynamics program in the NICU at Oklahoma Children's Hospital. And then we will wrap up with Anoop Kathiria, who's an associate professor of pediatrics and the director of the Neonatal Research Institute and the NICU follow-up clinic at Sharp Mary Birch Hospital for Women and Newborns in San Diego. With that being said, Jack, I'm going to give the floor to you. Thank you.
Fantastic. Let me share my slides. Oh, shoot. We're seeing the wrong one. Let me try this again. All right. Can you guys hear me and see the slides okay?
Yeah.
Okay, fantastic. Okay, great. So thanks for the chance. I'll try to be quick with the slides so we can move on to kind of more of the discussion. I think it'll be more helpful towards the end. So I'm going to be talking briefly about kind of as a very recent fellow graduate and somebody who still feels like they're basically a fellow, how to kind of see how you're doing and to make sure that you're progressing in your training. So these slides are kind of designed for somebody that's doing a typical 12-month hemodynamics fellowship, but recognizing that there are multiple ways of kind of achieving this training. So while a lot of these slides allude to the 12-month period, like I said, the general idea can be applied to however one is pursuing their hemodynamics education. So again, recognizing that this is kind of looking at the 12-month model, this is kind of how I think most of us would view the general trajectory of the kind of the focus of your training on a time-based approach. So as has been alluded to both in the T&E guidelines and in other talks similar to this, right, the early part of the T&E education is predominantly it's muscle memory and physical based, as in you're learning how to physically hold the probe, where to put it, how to get the image, and then tied tightly to that is measuring of the echoes. Now, this is recognizing that in some places you may be able to, as even before you start your hemodynamics training, you might be able to be measuring echoes in a research-based setting, but that's not true for everybody. So for many people, learning how to scan and how to measure will happen kind of side by side at the same time. And that's really going to be the focus of the first, really 6 months of training. While the arrow ends here at 6 months, right, we're always learning, we're always getting better at scanning. So I'm not saying that by 6 months you're going to be done learning how to be a good sonographer, but this is kind of for primary focus. Once you've started to kind of get, and this is as everybody's on here that knows as a trainee, once you've started to kind of get a hand of, what do the certain views look like, what are the planes that we're trying to achieve. Relatively early, you'll start moving into focusing more on initially the assessment, right? So how do you incorporate the pictures you get and the measurements that you have into a diagnosis? And then tied to that is then how do you incorporate into your assessment how to manage the baby? And this is going to provide kind of what I would consider to be kind of the meat of the fellowship, right? The first part is you're learning the scanning part, but right, the main component of training is not to teach you how to be a sonographer, it's to teach you how to use that information to develop a treatment plan for the patient. And then the final portion of training, whether it's your last 3 to 4 or 5 months, is using all that information, but learning how to do it in a consultant role, and then ultimately practicing independently while you're still a fellow, so that when you do move on, whether internally like I did or externally like others have done, like Marjorie will talk next, of how do you actually practice this independently while you still have some oversight and chances to learn. And then I've included here at the bottom just kind of reminders that throughout the whole process, it's important, one, to always be focusing on professionalism. When you have time, academic productivity, but wellness is critical. This is an extra year. It's a long process. Make sure that you're taking care of yourself throughout this process. So for each of these little ones, I'm going to go briefly through kind of how, what is the general trajectory and how to know if you're progressing well. So again, the first one is acquisition and measuring. So wherever you are, focus on your protocol. In general, this is going to follow the accepted T&E protocol that's in the T&E guidelines that were recently revised. Although every place might be a little bit different in their order, but whatever the protocol is, that should be the initial focus. Whenever you're able to do the scans, practice, as in get your hands on the probe and go scan babies. That's probably going to be healthy patients early on. If you're working with the cardiology department in this process, Echo Lab is a great place to do this, right? They have a lot of relatively healthy babies that are coming in for scans, so it's a great way to get used to scanning babies. And then simulators, if you have them, are useful, but it's most helpful to be actually scanning babies. So image whenever you're able to. Ask for help when you have trouble getting a view, right? So in the beginning, you're going to be just focusing on getting the certain planes and certain views that we're targeting. Everybody learns differently. I learned very early on that if somebody grabbed my hand and got the image for me, that did nothing for me. I needed them to kind of, it was more helpful for me to tell me how to get the view better, rotate counterclockwise, fan upwards, that kind of thing. Them just moving their hand to get the image didn't help me. Others of my colleagues, they learn very much by having somebody kind of guide their hand to the right area, and they get a feel for what it looks like. So you will learn as you're going through this process what's helpful for you, and make sure you advocate for yourself of what's the best way that you that helps you to learn. And in the beginning, it sounds kind of counterintuitive, but to me it made sense, is that target perfection early on, right? You're scanning healthy babies. You've got a certain time frame, depending on your center, that you're going to be scanning these babies in. You should be trying to be perfect early on, because the goal of the scan at that point is not to have an acute answer, an acute diagnosis. Your goal is to get good at the image, and so do everything you can to optimize the image, as opposed to trying to go as quick as possible. We'll talk about that later, about when eventually you'll move quicker. But in the beginning, focus on getting your pictures strong. The functionality component comes with time. So how do you know if you're progressing? Milestones are going to be key. A large component of this will be keeping a logbook. So if you're not already, keep a record of the babies you scanned, their weight, how long it took you, and what view you got to in what amount of time. Because that's ultimately going to be the best way to know how you're getting there. Now, again, the time component, it is an important piece, but in the beginning, focus less on how long it's taking you and focus more on optimizing and getting the right images. Once you feel good that you're able to obtain the images, then it's important to start looking at the time component. The final goal by the end of training is that you should be able to do a complete T&E in ideally 15 to 20 minutes is our overall target. Assessment, right? So remember that while in the beginning of training, and I felt the same way last year, everything I was focusing on was my image views, how the quality of the images, and how quickly I could do the scan. It wasn't really until about this time last year I started realizing that I'm not just a sonographer. I need to be focusing on other components. Knowledge acquisition. How can you improve yourself? So read's on here twice because it's very important, but it's incredibly hard to do because this is a hard extra fellowship and it's hard to find the time, but it's incredibly important. So find the time to read about the patients. The lectures that are like these that are online are great chances. You can put them on. Whenever I was driving, I would put these things on YouTube and listen to them when I was driving. And then any